double papillae repositioned flap is used to cover defects created by labial or lingual gingival recession. The recession and the thin labial periodontium on the adjacent teeth make the double papillae repositioned flap the treatment of choice for this defect on the left cuspid rather than a lateral sliding flap. A double papillae flap procedure for the cuspid will be demonstrated. The gingiva in this area has been anesthetized. A Bard-Parker number 15 blade is used to remove the epithelial lining of the free gingiva bordering the cleft of recession. The incision is made to undermine the attachment of gingival tissues and extends through the attached gingiva into the alveolar mucosa at the apical border of the defect. A sharp curette is used to remove the excised lining of a gingival crevice. The curettage is extended subgingivally to ensure complete removal of the epithelial attachment. A thorough root planing should include the removal of the surface layer of the exposed root. The root must be planed until firm tooth substance has been reached and the root is absolutely smooth. In some cases, it may be impossible to avoid exposing dentine, although this is not the aim of the treatment. A vertical incision is started between the cuspid and lateral incisor and extended into the alveolar mucosa at the mesial aspect of this interdental papilla. A similar incision is made at the distal aspect of the papilla between the cuspid and first bicuspid. The mesial graft is separated from the underlying tissues by sharp dissection utilizing a Bard-Parker 12B blade. Care is taken to create a graft of even thickness. The dissection is carefully performed on each side of the mesial graft until it is freed from the underlying tissue. This same procedure is then performed on the distal graft until it is also separated. As stated before, the thickness of the grafts should be kept as uniform as possible. After the marginal aspects of the two grafts are separated from the underlying structures, they are reflected from the alveolar process with a mucoperiosteal elevator. The reflection of these two papillae is performed in such a way that they can be positioned together over the labial aspect of the cuspid tooth. The two grafts are sutured together with 5/0 silk suture. A fine atraumatic needle is used to prevent the tissue from being torn as it is passed through the papillae. The grafts must be handled very carefully to avoid interference with the blood supply from surgical trauma. The depth of the bite of suturing should be shallow and yet provide adequate retention for approximation of the two grafts. The papillae are sutured together, starting at the apex of the cleft and then proceeding toward the cemento-enamel junction or cervical line. Sutures are placed so as to permit union of the papillae without affecting their vascularity. The two cut surfaces are brought into close contact to enhance healing by primary intent. Only the minimum number of sutures needed to hold the grafts together should be used. In this case, the grafts will be adequately unified with 3 sutures. The tip of a unified graft is too narrow to cover the root surface and is trimmed off with surgical scissors. In order to secure the desired position of the united flap over the denuded root surface, a suture needle is passed from the palatal aspect between the cuspid and the bicuspid teeth and the suture drawn to the labial side. The needle is then inserted through the distal half of the flap and pass back through the same interproximal space. This suture is passed through the interproximal space between the lateral incisor and the cuspid tooth from the palatal side. It is then inserted through the mesial aspect of the flap. After the suture needle has again been passed through the same interproximal area, the sutures are tied on the palatal aspect of the cuspid. A gauze sponge moistened with sterile saline solution is used to place the flap in the desired position and to hold it firmly against the tooth for about 1 minute. Two and 1/2% ophthalmic acromycin ointment is placed over the area of the surgery. Dry foil is adapted to the area of surgery with a gauze sponge. The surgical dressing is applied over the foil. It is molded to the tissues and adapted interproximally with a plastic instrument. border of the dressing is molded with the lips, so it does not impinge upon the mucobuccal fold after it sets. Surgical dressing is also placed on the palatal aspect to protect the area of the surgery and secure the suspensory suture. The occlusion is checked to assure that the dressing is not interfering with occlusal function. This is the operative site 1 week after surgery. The surgical dressing has been removed. There is some debris on the surface of the graft, but the surgical defects are filling in with granulation tissue, and the grafted flap is vital. The sutures have now been removed. The two initial grafts are well united. Acromycin ointment is again placed over the area of surgery, and a new surgical dressing is applied. This will be left in place for 1 week. Three weeks post-operatively, the gingival tissues have not regained their normal color or keratinization. However, the previous cleft has been covered by the flap, which appears to be attached to the denuded root. In addition to the improved aesthetics, there has been a gain of attached gingiva over the cuspid. 5 months post-operatively, the grafted area has healed well. As evidenced by probing, the grafted papillae have become attached to the labial aspect of the cuspid in the area of the previous labial cleft. The aesthetic and functional results appear to be excellent.